Good afternoon, everyone, and once again, welcome to e-NISCHIT, our little effort, our national initiative to strengthen collaboration between HIV and TB through e-learning. And I am once again thankful to everyone for taking out this time. With these few words, can I please welcome our expert for the day, Dr. Daljit Singh Sethi. He is the medical director of Hope Clinic Shillong in Meghalaya. And I'm very sure that all the people who have joined from Northeast today would be familiar with him and his work. After welcoming him, I welcome the presenter for the day, Dr. Krishna from Kakinada ART Center. And of course, I welcome all my ART centers. So while they're pulling up the attendance poll, let me talk a little more about this session today. Today is a very, very important session. Again, it is HIV, again, it is TB, but it is something that we have not covered till now, and that is cardiac manifestations of tuberculosis. And how do we get to know that the patient has a cardiac problem? How do we finally diagnose that this problem is tuberculosis? And once we have diagnosed that this problem is tuberculosis, what all treatment to give? So this is actually a unique case. We have not discussed any of these over the past 2.5 years that we have been doing this case. And I'm very thankful to the Kakinada medical officer for showing us this case and for making it a beautiful discussion today. So the topic for today is to understand the line of treatment in a PLHIV diagnosed with pericardial effusion, which is tuberculous pericarditis, and the possible of cardiac complications with anti-tubercular treatment. With this, I would request Dr. Krishna from Kakinada ART Center to kindly present the case.
Thank you, ma'am. Good afternoon, everyone. Myself, Dr. Krishna Kumari, a medical officer at ART Plus Center, Kakinada. Today, I'm going to present a case related to 38 years old female who was diagnosed to have a pericardial effusion due to tuberculous pericarditis with bilateral pleural effusion associated with cardiomegaly. The reason for the case presentation is, what is the better line of treatment in this case? What would be the possibility of cardiac complications with anti-tuberculosis therapy? Coming to her ART and medical history, ART registration was done on 11th December 2015. ART initiated on 27th February 2018. Date of TB confirmation on 5th April 2021. Anti-tuberculosis treatment initiation was done on 22nd April 2021. She has no past history of TB. She was defaulter for isoniazid preventive therapy. She is on ART since 27 February 2018, initiated on TLE regimen. She was regularly irregular at the time of pill pickup at ART center. Later, patient went on LFU in 2020 for a period of 6 months. That is from 2nd April 2020 to 27th October 2020. She was tracked back to ART center on 28th October 2018. She was evaluated with the routine investigations and screened for opportunistic infections, after which investigations were within normal limits and no opportunistic infections were observed. Later, she came to OPD on 28th March 2021 and presented with complaints of fever and cough. CBNAT was done, not detected for tuberculosis, and there is no rifampicin resistance seen. She was also presented with complaints of retrosternal chest pain, which was aggravated by coughing, was relieved by bending and leaning forward. Patient also had a history of bilateral leg swelling, breathlessness on exertion, giddiness was present occasionally, loss of appetite was present, weight loss was observed. On examination, severe anemia was elicited. She was admitted in ward on 30th March 2021. During the further evaluation, she was diagnosed with extrapulmonary TB, which is tuberculous pericarditis, and bilateral pleural effusion, initiated on anti-tuberculosis treatment with CAT1 regime, fixed dose combination, 3 pills per day, along with TLE regime. She was inpatient in ward for 10 days and treated with antipyretics, antibiotics, and drugs like antidiuretics. Ceptron DS was also initiated. Fluconazole also given. Patient was discharged with empirical antibiotics. She was improved after the treatment. Fever subsided. Bilateral pedal edema reduced. Symptomatically stable after administration of anti-tuberculosis therapy along with ART after 1 month of duration. Later, efavirenz was substituted with dolutegravir due to programmatic change. Additional booster dose of dolutegravir 50 mg was also given to the patient. Now she is regular for her pill pickup at ART center as well as ATT utilizing single window services at ART center. Her lab investigations, CD4 counts at the ART initiation, 342 cells, which was done on 22nd Feb 2018. Her last two serial CD4 counts are 355 cells, which was done on 19th February 2019, and 232 cells, which was done on 31st March 2021. Her viral load report is showed 284,343 copies, which was done on 31st December 2019. And her serum creatinine and liver function test and kidney parameters are within normal limits. Complete blood picture showed decrease in hemoglobin, that is 8.1 1 gram per deciliter. In complete urine examination, albumin was present. CBNAT was done, MTB not detected. X-ray also done, showed left paratracheal lymph node enlargement. 2D echo was also done on 4th April 2021, which suggested mild pericardial effusion with ejection fraction of 45%. HRCT was done, showed bilateral pleural effusion. Right side is more than left side with pericardial effusion and cardiomegaly. Peripheral smear also was done, so suggested of microcytic hypochromic anemia with thrombocytopenia and neutropenia. Her current ART regime is TLD plus DTG. She is on ATT continue phase of HRV, fixed dose combination of 3 pills per day. She weighs 40 kg. She is also taking cotrimoxazole prophylaxis therapy, other medications like Lasix, antifungal treatment, and iron and vitamin supplementation. The issue for the case discussion is current anti-tuberculosis treatment CAT1 4 fixed dose combination is sufficient in this case. Diuretic can be helpful or suggest a line of management.
Yeah, so thank you very much. Have you completed, Dr. Krishna, or would you like to add anything?
Oh, ma'am.
Yeah.
Yes.
So yeah, so just a very, very brief summary. You did a very, very good job. So a very brief summary. There's a 38-year-old female. She is a PLHIV. She had the opportunity to be started on ART way back in 2018, but she was irregular. Then she totally was totally lost to follow up. She came back. Then when she came back in 2020, I think again she was started on ATT. But 6 months after that, she developed some problems like severe chest pain, coughing, bilateral neck swelling, pedal edema. And when an echo was done, when an ultrasound was done, when an X-ray was done, it showed a right paratracheal lymph node plus a cardiomegaly, which on an echo and ultrasound chest, they found out to be pericarditis. And she also had bilateral pleural effusion. So with this background, another thing that happened because of her frequent non-adherence was that her viral load was high.
Yes.
So her viral load is high, and she had not yet had a chance of taking ART in a duly diligent form for 6 months to 1 year. So probably we cannot label her failure as yet, even though she has developed TB. But this is basically a clear-cut case where the patient is not taking medicines. So if the patient is not taking ART, we cannot actually evaluate the person for the past 6 months. We cannot say whether the patient has failed or whether the patient is just not taking drugs. So with this background, but the fact remains that her viral load is very high, and that must be leading to some immune suppression. If you would see the CD4s, they're also very interesting. It was 355 in February. Then for some reason, the next CD4 was less. It was about 20 to 25% lesser than that was seen in 2019. And that is the time when she also developed tuberculosis. Soon after that, she developed tuberculosis. Probably I have missed it, but did you do any TAP?
No, ma'am.
Pericardial TAP?
No, ma'am. I think that maybe they have done. I don't have any investigation regarding that.
So who started the ATT for this patient? Who made a diagnosis of pericardial effusion?
Actually, she was admitted in medical ward, general medicine ward. So they have diagnosed and they have sent to us, ART center, as she's already on ART.
Correct.
So we initiated on ATT after
Yeah, I understand.
Yes.
Yeah, I understand. So it's clear that it was she admitted pericardial trap or a pleural trap, which could have given evidence of excess protein sugar, and they would have started ATT on the patient. So I think it's a very, very well worked up case. It's a very relevant case. Thank you, Dr. Krishna, for such a clear presentation. And now I would like to request Dr. Daljit Sethi to shed some light on this problem that this center faced in a PLHIV of cardiac TB, and help us, the whole house, learn how we should manage such cases. Over to you, Dr. Daljit.
Good afternoon, and thank you, madam. Am I audible, madam?
Yes, sir. You are audible, sir.
Yeah. Are my slides visible?
They are visible, sir. You can go to the presentation mode, please.
Yeah.
Yeah, they're absolutely visible, sir.
Well, at the outset, I must share that I am not an expert on ART, and you will forgive me my shortcomings when it comes to the field of administering ART in tuberculosis patients. Well, tuberculosis and the cardiac involvement is extremely important, particularly in the rural and undeveloped areas of our country. If you would ask me, coronary disease is not as important. Rheumatic heart disease is on decline. However, tuberculosis and the cardiovascular involvement has not shown any decline. We still see pericardial effusion almost every week, and many of them are related with HIV. So just to take you through the case again, this was a 38-year-old on irregular ART since February 2018. So after 2 years, he was lost to follow-up and stopped ART. And then in October, came back, was put on ART, and no opportunistic infection was detected. Well, then after 5 months, she developed fever, cough, but then CBNAT, though rightly suspected, but this was negative. At this point, after 2 days, she was admitted, diagnosed as TB pericarditis. This was the time that she showed pericardial effusion and bilateral pleural effusion, and was put on ATT. About a week later, patient was discharged, was followed up after about 15 days when the patient had shown improvement. Now, this is a classical presentation, and this improvement is very gratifying to the physician as well as the patient. Well, we have some issues for discussion. The current anti-tubercular therapy, is it sufficient in this case? The second question, which arose, that if you have a cardiac patient with something diuretics usually up in, will diuretics be helpful? What should be the ideal line of treatment? I would also put a question which comes, are steroids necessary here? How do we follow up such a case? Now, around 10 million people across the world acquired tuberculosis, and of this, roughly about 85% are in low middle income countries. And definitely, there is a very close relation with poverty. Tuberculosis confers significant burden of disease. There is an increase in mortality. Low middle income countries account for 40 to 70% of all recorded cases of pericardial effusion. This includes even non-tubercular effusion. So all over the world, about 70% of the tubercular effusions are seen in low middle income countries, and they caused 1.5 million deaths. This is data from 2018. Immunosuppression is a crucial risk factor in acquiring TB. And what I would like to share is that patients with HIV are about 10 to 16 times at higher risk of getting tuberculosis. On the other hand, just about 8.6, about 9% of patients with TB have HIV infection. So what are the other risk factors? Glucocorticoids. We have an unregulated pharmaceutical industry, and glucocorticoids are given to practically anybody with a breathing difficulty. Poor nutritional status. We are a developing country, but our rural areas still have this problem of poor nutrition. And while the communicable diseases are still with us, we have a huge burden of non-communicable diseases like diabetes and cardiovascular disease, where people with diabetes are so much susceptible to tuberculosis. What is the pathophysiology and cardiac involvement? Now, the cardiovascular structures involved could be the pericardium, myocardium, extremely rare cases of endocardium, but a small amount on aorta, about 0.3%. So about 2 to 5% of patients have pericardial, and about they should be 0.14 to 2.0% have myocardial involvement. So the commonest, which is the pericardial involvement, is very common in patients with AIDS. The TB pericardial effusion in patients with AIDS is 85%, whereas in the general population, that is patients without AIDS, only 5% of the population develop pericardial effusion of tubercular origin. What are the presentations of cardiac involvement? It could start from the pericardium. There could be acute pericarditis, followed by pericardial effusion, myopericarditis, and these could go on in the long run develop constrictive pericarditis, although in rare cases we see an overlap of constrictive pericarditis combined with myopericarditis and effusoconstrictive pericarditis, where you see effusion as well as constriction. So the spread of the organism is mostly lymphatic. However, in patients with AIDS, it is also hematogenous, where patients with AIDS have miliary tuberculosis. What is of concern is constrictive pericarditis in the long run. And in endemic countries, tuberculosis is the commonest cause, and tuberculosis accounts for 38 to 85% of all cases. Now, anybody during the process of developing cardiac tuberculosis, be it just effusion or pericarditis, develops transient constriction in about 10%, just before they see a doctor, and the doctor puts in a needle, wanting to get the fluid, to get the investigation done. If there is no treatment, the constriction occurs in 20 to 50%, which should be despite treatment. This may persist for several years, causing heart failure. Now, these are some of the pictures to show you the presence of the bacilli in the myocardium. Here you see the myocardial involvement where the myocardium itself has high echo intensity. On the Doppler, you see the Doppler changes to suggest pericardial constriction. Another, this is again an image, the MRI image, to show the pericardial effusion, the pericardial thickening. Now, although TB myocarditis is less, now by and large, the spread is hematogenous. It's interesting to know that tuberculosis has a predilection for right mediastinal nodes. And therefore, the right side of the heart is predominantly involved in those very rare cases of myocarditis. As I shared earlier, less than 50 cases of tubercular endocarditis have been reported across the world. Now, few cases in the young have aortic involvement, and this is from Vasa vasorum, and where these bacilli go and implant on the atherosclerotic plates. Let us see what are the presentations, and this will help you to clarify your doubts on the pre-test poll. The chest pain in 41% is in 46%, dyspnea 44%, fever is predominant and occurs in 73%. A pericardial rub is heard in 39%, paradoxical pulse in 39%, hepatomegaly in 44%. If we see the chest X-ray, cardiomegaly is seen in 98%, pleural effusion in 41%, parenchymal lung lesion in 15%, hilar lymphadenopathy in 10%. What are the signs that we elicit? There is a tachycardia in 70%, pulsus paradoxus in 48%, 100% have increased central venous pressure, almost all. There is a palpable apical impulse in 58%, increased cardiac dullness in 25%, a pericardial knock, which was so much emphasized by our teachers, is not so commonly heard, a muffled heart sound in 76%, and S2 split in 36%, third heart sound in 45%. Almost everybody has a hepatomegaly. It is also contributed by the right-sided pleural effusion. This is widespread. The tubercular infection many a times is widespread, and therefore we get ascites and peripheral edema, which is contributed by so many factors. Now, what is important to know in tuberculosis, that even the acute pericarditis is not so acute. Unlike a viral pericarditis, where the patient shrieks with pain, this cancer, acute pericarditis does occur with a little bit of pain, and it does, and the patient goes about his life before he develops a breathing difficulty, cough, and fever. The stabbing pain and rub, the so-called the common pericardial rub, is not very common, just about 3 to 6%. Systemic signs are much more common, and these we just elucidated. The signs and symptoms depend on the rate of fluid accumulation and the hemodynamic effect on the heart. The contraction, that is the LV function, depends on the degree of inflammation that has occurred. However, but if the fluid accumulates very rapidly, then again it is not the pain but the tachycardia, hypotension, and if we don't treat, 50% will progress to tamponade, and the mortality is as high as 85% at 6 months without treatment. What are the other features? There's a disturbance of conduction system, which manifests as long QT syndrome, ventricular fibrillation or cardiac arrest, which is a chronic development, gradual heart failure. At times, the patients are asymptomatic and diagnosis is made at post-mortem. Aorta is a very rare involvement. I have not seen any features of pseudoaneurysm or mycotic aneurysm, versatile or palpable mass in chest or abdomen, and at times there is aortic rupture or there's valvular insufficiency. Now, this is a flow chart which you could follow, and this is to help you. And with echocardiogram so readily available, as soon as our patient has cardiac symptoms, it is mandatory and reflexively we need to send him for an echocardiogram. This will immediately diagnose pericardial fluid. No echocardiograph, no cardiologist worth his salt can miss pericardial fluid. Even our ultrasonologists always tell us, if pericardial fluid is there. Here in our tubercular OPDs and clinic, a point of care ultrasound, a point of care echocardiography is considered extremely helpful because you diagnose it in minutes. Even a chest X-ray takes longer. And it not only diagnoses, it helps you where to put your needle and draw the fluid. So I find it extremely, extremely useful. If the pericardial fluid is minimal and you feel that you can't tap it, look at the pleural fluid. It's so easy to tap. And there again, the point of care ultrasound does help. Put the probe, put the needle. It's most likely that the two fluids share the same characteristics and help us arrive at a diagnosis. However, if the symptoms are not very prominent, but then you see an abnormal ECG or a cardiac Shillong, which is a cardiomegaly, we again send for echocardiogram. And once we have the pericardial fluid, we are able to do the interferon gamma, we do the ADA, PCR positive, and so on. We put the patient on tubercular therapy. Even if it is not present, but our symptoms are so suggestive, we may not have pericardial fluid, but we have pleural fluid. It gives us a reason to start empiric anti-tubercular therapy. And once the features on the fluid, either from both the areas, pleural or pericardial, are negative for ADA, PCR, CBNAT, need to exclude other causes. Well, imaging, like in this case, is very helpful. And those of us who do echocardiograms regularly, when we are doing, we see fibrous strands in the pleural fluid, which are so very characteristic of tuberculosis, and we have a reason to start anti-tubercular therapy, even though we are in a position where MRI is not available or an AD or PCR is not available. Wherever possible, if there is a suspicion of aortic disease is there, we should try and get a CT scan done. There, the echo is less helpful, and then this will help us to come to a conclusion whether the aorta has a tubercular involvement. So the aorta will have, yeah, this is what I just finished. I'm sorry, I came back. So yeah, these are the diagnostic index. And we have a diagnostic index of night sweat, weight loss, fever will have 2, white blood cell count will have 3, serum globulin more than 40 will have 3. Here, this was a question, score of 6 or greater suggests tubercular pericarditis. I hope this will help you arrive at a diagnosis and help you to answer the post-test question. So, come to the treatment. The treatment is no different. In fact, it doesn't mean that if the heart is involved, you need a tank. you need some very major, very strong, powerful drugs. No, the drugs are the same. Now, the treatment is based on a 4-drug conjugated antitubercular chemotherapy associated with corticosteroid. Here, because the inflammation is so much, the symptoms are so rapidly developing, we need steroids to tone down the inflammation. Please remember, there are arteries in the pericardium, be close to it, and we don't want the arteries to get inflamed and develop vasculitis and giving rise to myocarditis and coronary artery disease. Drainage is extremely important. This drainage could be either open, on, or cutaneous. Now, without doubt, antitubercular therapy has shown significant decrease in mortality, and this is especially so in patients who are on ART, in patients living with HIV. 4-drug regimen is same as for pulmonary clots. Well, in low middle income countries, multi-drug resistance is a problem, and this resistance is to be tackled by the protocol outlined by the national tuberculosis programs, and the same needs to be followed for the cardiac tuberculosis. Well, the question comes is, the moment you have tuberculosis, you have a patient with AIDS, so there is a bacteria, there is a virus, you need steroids. In earlier days, the decision was always left to the professor, because it was found, it was believed that the steroids have a controversial look. But now it is clear that they are beneficial. They decrease the incidence of death, development of chronic constrictive pericarditis, and they decrease subsequent hospitalization. Cardiocentesis. Any emergency physician worth his salt should be brave enough to put in a needle if he suspects pericardial tamponade. This is the most life-saving procedure. All that you need is take any large bore needle, 19 plus, or any large needle, and just put it. Believe me, have courage. If the effusion is large, you will never hit the heart. You will save the life of the patient. Undoubtedly, surgical drainage is more effective, but it's not always practical. We need a lot of preparation, and remember, these patients have a lot of comorbidities. Pericardiectomy will be ultimately required in 20 to 50% of cases. What is important here is pericardiectomy should be preceded by 4 to 8 weeks of antitubercular therapy. Will the current ATT in this case is sufficient in this case? The answer is yes. Will diuretics be helpful? Well, if there is a myocardial infarction involvement and our patient is in heart failure, yes, diuretics will be helpful, but otherwise it could be counterproductive. It will shrink the vascular volume and decrease the cardiac output. What are the suggestions for follow-up here? Well, we need to follow them up for development of chronic constrictive pericarditis and timely referral to our surgical colleagues. The ideal line of treatment again is same for pulmonary clots, but be on the watch out, look at the JVP. We need to do the chest X-ray maybe a little more frequently, especially in the peripheral areas. An echocardiogram, follow-up echocardiogram will tell us how much the fluid has reduced. There is no difference in the treatment regimen. To conclude, cardiac involvement in tuberculosis is frequent and can lead to heart failure, constrictive pericarditis, or death. The manifestations are diverse. The early detection is of utmost importance. We need to improve availability of diagnostic tools like ADA, interferons, echocardiogram, and cardiac MRI. a combined treatment with ATT and close follow-up of these patients is required. With this, I'll take 2 minutes, and this was day before yesterday, and look at the heading, and this is by Anthony Fauci, tuberculosis, an ancient disease in need of modern scientific tools. I've read the article, so I can just share the gist with you. The global data is a new cases of 10 million and 1.3 million deaths after all these years. Now, this statement has come in response to the response of the industry, the scientific community, COVID. And let me tell you, the statement is an indication of the rapid development of vaccines, the coronavirus. Look at the number of vaccines which were developed. They were all developed in a couple of months, and they were also effective. So I would pose a question to you: why is it so? Why does it not happen with tuberculosis? BCG is more than 100 years. It is somewhat effective in preventing meningitis in children. There we have the hard data. But if it were so in adults, we would have no tuberculosis now. This is because it has limited durable protection against pulmonary tuberculosis. Therefore, like COVID-19, we need more effective vaccinations. Is it so that COVID-19 affected the rich countries? They were affected, they put in a lot of money, but tuberculosis is not a problem in the rich countries, and therefore we don't have that robust response from the industry when it comes to tuberculosis. Well, there have been some developments, and it has been conclusively proven that effective immunity is achievable. And this is by National Institute of Allergy and Infectious Diseases. And what is also enlightening is that if you give BCG IV rather than subcutaneous or intradermal, because given the BCG is highly protective, we need to discuss this in the course of our findings. So this was the global TB report. It shows a lot of concerns, and the key message, the overarching message is the COVID-19 pandemic has reversed years of progress in providing essential TB services and reducing TB disease burden. The global TB targets are mostly off the track, although there are very few regional success stories. And look at the big drop. This is the most immediate and obvious impact of COVID-related disruption. There's a big drop in the number of people with newly diagnosed TB and reported. This is a very serious issue, particularly in our country. Our country has led the world in non-reporting of tuberculosis cases. And look at India is on the top. 16 countries accounted for 93% of global drop, which India alone took the cake at 41%. And this is a huge drop when it comes to India. This is a serious concern. Our government has woken up. Yesterday, I received a circular from the local health authorities regarding information to the government whenever our pharmacy dispenses any anti-tubercular therapy. I believe this is in response to the underreporting that has happened during and after COVID-19. I think we all need to get together. We are missing a large number of tuberculosis cases, a large number of tubercular pericardial diseases, and hopefully we should together be able to overcome this deficit. I must thank the organizers for allowing me to share these precious moments with you, and I will be very happy to take in questions regarding cardiac tuberculosis.
Thank you, Dr. Sethi. That was an amazing presentation. Crystal clear. First, I would request the Kakinada team, are they clear about what they had asked? Do you have any questions from the expert, ma'am?
No, that is ideal management and follow-up care has been cleared. So
Yes.
that's all.
You have done a brilliant management. Yeah.
Thank you, sir. Thank you. I mean, my sincere thanks to you and heartful thankful thanks to you because for accepting my case and for the discussion also. So seriously, thanks.
So I'll just summarize what's said for the benefit of all the ART centers available. So as Sir said, that cardiac TB is a very important aspect of TB, and it is more and more in people who live in lower to middle income groups. The most commonly affected cardiovascular structure is the pericardium, then the myocardium, and very rarely the aorta. And if you will look at the cases of pericardial effusion, then 85% of them are seen in HIV positive cases, and only 5% of them are in the HIV negative population. When it comes to the presentation, we have to understand that pericardium gets seeded by the lymphatic spread, the myocardium by blood, and the aorta probably by vasa vasorum and the atherosclerotic plaques which are present around and in the arteries and the aorta. And as Sir told us that you could have any kind of, you could catch the patient at any time. There could be an acute pericarditis when you catch him. You don't catch him, then it could become a pericardial effusion. And if you don't catch him, then too, it could be a myopericarditis, or the differentiation between these stages might be very less. Like he might just suddenly develop pericardial effusion and a myopericarditis, and then it could go on to a constrictive pericarditis. And this constrictive pericarditis is obviously a matter of concern. It is transient in about 10% of people, but can stay persistent in a large number of cases. And in 50% of cases, even despite treatment, it might persist. So constrictive pericarditis is a very, very important long-term sequelae, I would say, of pericardial TB, seen very frequently. And it is something that we would really not want, because once the patient goes into constrictive pericarditis, then we have right heart failure leading to left heart failure. And then there are so many complications, like it starts a whole cycle. And as Sir said, periodectomy is not for everyone. We need 6 weeks of treatment first. And then not everybody might be fit. Many of our HIV patients might not have access to a center where they do pericardiectomy. Sometimes getting a surgery in an HIV positive is a big issue. Nobody wants to touch a patient in the OT who has HIV. So I would suggest that our best bet would be to pick it up early. Yes, as Sir said, despite treatment, people might get it, but still early diagnosis is early diagnosis. And as he told you, if you get a person who has dyspnea, who has palpitations, and who is coughing or shortness of breath, you should also have a look at the heart. If you see an X-ray where the cardiac slit is enlarged, please go ahead and examine the patient. Look for a raised CVP, look for muffled heart sounds, look for pedal edema, look for ascites, look for liver enlargement. Basically, some features of right heart failure, along with tachycardia, increased CVP, and muffled heart sounds. So this should be our line of management. And if once we suspect that, okay, the heart might be involved in this patient, please go ahead for an echo. An echo is not a rare test now. Echo is easily accessible. An echo and ultrasound of the chest, like hospitals like ours have ultrasound of the chest and not exactly echo. So there you could probably locate that the patient has pericardial effusion. And you can also see other things like pleural effusion in the same setting. And now it would depend upon tapping the fluid and finding out. See, the general idea is to go for the least invasive sample. If you could first try for a sputum. If the sputum CBNAT becomes positive, you do not need to touch a sterile cavity like the heart. Okay. If you cannot get a sputum and the patient has pleural effusion, next would be that you tap the pleural effusion. If you can get evidence of TB from there, very good. No need to touch the sterile cavity. But if you're not able to reach a diagnosis, please go ahead and do a diagnostic pericardial centesis. And if required, a therapeutic also, if you feel that the patient is in impending tamponade or impending increased pressure on the heart. Tamponade might not be a correct word. A tamponade is when you actually, your cardiovascular system starts collapsing, you don't have proper, your vitals are not sustainable. And then, as Sir said, it becomes an emergency, and you should be able to relieve the stress on the myocardium by tapping fluid from the pericardium. A surgical drainage is always better, but you could also do like an open surgical one is better, but there is something known as a percutaneous one also, which you could do through a needle, and sometimes even leave a indwelling catheter and probably give relief to the patient. Well, when it comes to treatment, the treatment is, very important. Before the treatment, Sir told us a score. He told us a score for pericardial TB. How many of you are clear on that? I really wanted you people to be clear on that. Is everybody clear on that? Everybody who's clear, please raise their hands. Who are not clear, please raise their hands now. You want, yes, ma'am. Sir, please, can you repeat that criteria for pericardial TB? It's a very new concept for our ART center. We would like to hear it again.
Well, I'll go slow and get on to the criteria here. So, yeah. So, this is the score. If a person comes with night sweat, the score is 1. Weight loss is given a score of 1. Fever given a score of 2. Leukocytosis, WBC count more than 10,000 is given a score of 3, and a serum globulin greater than 40 is given a score of 3. So there are these 5 parameters, and if you add these and you get a score of 6, it suggests tuberculous pericarditis. Remember, it suggests you are the clinician, and the diagnosis is not made by any scores. The diagnosis is always made by the clinician.
Yeah. Thank you, sir. Thank you, sir. So you see what a nicely beautiful simplified score it is. Doesn't need a lot of brain work also. These are simply accessible tests. First 3 are just symptoms that you have to take, and a fever that you have to measure, a WBC count, and a serum globulin count. And as I said, your score might or might not be more than 6. But if you feel as a clinician that this patient has pericardial TB, please give the benefit of doubt, especially in a HIV positive patient. An HIV positive patient, TB should always be given the benefit of doubt. Like for a HIV positive patient, the TB is the batsman of cricket. Like in cricket, the benefit of doubt always goes to the batsman. So in HIV, the benefit of doubt always goes to TB. So if you feel, okay, it's not meeting this, it's not meeting that, patient has fever, he has night sweats, I can't see any TLC raise, I can't see any change in globulin, and you feel it's a TB diagnosis, please go ahead. And the treatment would remain ATT, like it would be given in all other cases, the 4-drug ATT for drug-sensitive TB. And the thing is addition of steroids. As in the case of tubercular meningitis, you want to add steroids to save life and to prevent sequelae. Similarly, in a case of pericardial TB, you would want to add a short course of steroids to save life, because we don't want the patient landing up into chronic constrictive pericarditis and then dying of heart failure. And also, it also prevents in further sequelae like frequent hospitalizations, or rather complications like hospitalizations. So please go ahead and add a short course of corticosteroids if you have a patient of pericardial TB. Drainage is always an option, open more than surgical. And I think these were the last few words, and I think this summarizes everything that Sir told us. Of course, I cannot summarize his beautiful presentation in 5 minutes, but I just try to do that so that it becomes clearer for our clinicians sitting there sometimes to hear it one after the other. So if anybody wants to like ask anything from sir or want to clarify something more, I think he would be more than happy to tell us.
May I come in?
Yes, please do, sir.
So, good afternoon, sir.
Good
Sethi.
afternoon. Good
Yeah,
afternoon.
Mr. Mori. Yeah. Sir, nice to hear you, sir.
Yes.
After a long time.
Can you switch on your video? We like everybody to see you.
So actually,
Okay. Dr. Modi is our state tuberculosis officer, doing
Oh,
excellent
great.
work in the country.
Oh, Dr. Modi, so we are so
Mhm.
happy to have you with us. Thank you so much for joining us.
Actually, regarding the pericardial fluid, which test is more sensitive, sir?
Okay. I will give you the practical solution.
Okay.
Number one, look at the fluid. You can easily know if it is an exudate. People who do tap fluids can just hold the fluid and know that it is an exudate. Well, we go through the traditional route. We look at the serum albumin, we look at the leukocyte count, and then now that, Dr. Mori, you have the facility of CBNAT and interferon alpha. These are now helpful, but then it is not that if you are if these investigations are not there, you will hold back the treatment. It is your clinical judgment, the setting of the individual. Like Madam Upasna just said, you have to give the benefit of doubt, especially in a person with HIV. I mean, I start treatment just on looking at fluid. We are an endemic country. We are not looking at very rare organisms here. And we give the benefit of doubt. Yes, we have the facilities provided by the government, and we send the fluid for these sophisticated tests. I generally do not require MRI or CT scan in all these cases. A simple tapping of fluid, looking at the count, looking at the albumin level, finding out if it is an exudate, all that is enough for us to go ahead and treat.
Okay.
Yeah.
Thank you, sir. Yeah, clear. I'm clear about that.
Yes, sir, I'll just like to add to that. For
Yeah.
like any fluid in the body, high protein, low sugar, and some cells, especially lymphocytes, would be an evidence for tuberculosis. Then, as Dr. Sethi said, we now have CBNAT and some places ADA also. So even though ADA is not a microbiological test, but it is still an indicative test, which does tell us, at least in these difficult to achieve samples, whether the patient is tubercular or not. And there was something very, very good that Dr. Sethi had said. When you do an echo, if you can see fibrous strands in the pleural cavity, or for that matter, in the ascitic fluid or in the pericardial fluid, that is almost a given that it is an exudative, and an exudative in India would be a tuberculosis. You would not be expecting a bacteria to give this much of exudates or staph-like infections. So if you see exudates, if you see those fibrous strands on the echo, then I think you can safely say it's a case of exudative infection, and that would be tuberculosis in Indian scenario.
Okay, thank you so much. Thank you.
So is everybody clear? I think we are now out of time also. Have we done the post test while I was talking, Anuradha?
Yes, ma'am. We have done the post test and feedback both.
Oh, great. Thanks for keeping us on time.
Yes, we wanted to listen to you more, ma'am, answer so that we utilize that time.
So can we now have the answers of the post test?
Yes, ma'am, sure. So with your request of doing the recapitulation, in fact, it was a great idea, and it helped many of the participants to attend their post test also. So the question was, tuberculous pericarditis index consists of which of the following parameters? And it was very clearly given in one of the slides. The option A is correct here. That is fever, night sweat, weight loss, serum globulin, and WBC count. Now, the second question was, in the tuberculous pericarditis index, which index score indicates pericarditis? And the option B, that is a score greater than 6, that indicates pericarditis. So that is the correct option.
Thank you so much, Dr. Radha. And once again, I thank our expert, Dr. Kohli. Sorry, I'm so sorry, sir. So Dr. Sethi, and we would be doing this session again for states of Delhi and Haryana and UP, Delhi, UP and Haryana on the next Thursday. If anybody would like to join in, they are most welcome. I thank the ART centers for joining in. And I also thank my team from Share India and Echo India. And a big thank to Dr. Sethi once again. With this, I would like to sign off. Thank you so much for your time.